Hi everyone, how are we feeling? Good? All right, I just want everyone to stand up real quick, stretch out your legs, stretch out those arms. All right, good. Now everyone have a seat and I'll begin. So like Beth Oliver said, my name is Michelle Gigante. I work on 7 East, which is the cardiac step-down unit here at Mount Sinai Hospital. And today I'll be talking about post-intervention handoff best practices. Okay. On today's agenda, I'll discuss nursing handoff, national patient safety goals that were developed by the Joint Commission, the importance and barriers to patient handoff, tips to achieve high-quality handoff, and how handoff is conducted here, from cath lab to inpatient units, as well as CSDU or CCU to 7 East or 4 North, which is our sister unit. So what is nursing handoff? Nursing handoff is a transfer and acceptance of patient care responsibility achieved through effective communication. It's a real-time process of passing patient-specific information from one caregiver to another or from one team of caregivers to another. Ultimately, this ensures the continuity and safety of the patient's care. National Patient Safety Goals is a quality and patient safety improvement program. Again, this was developed by the Joint Commission in 2003, and every year information is gathered about emerging patient safety issues. In 2006, the Joint Commission created the National Patient Safety Goal that addresses communication. This goal is to improve the effectiveness of communication among caregivers. In 2010, this requirement became a standard. The Provision of Care Standard requires that the organization's process for handoff communication provides for the opportunity for discussion between the giver and the receiver of patient information. Handoff is important for the continuity of care, patient safety, collaboration, and patient satisfaction. Continuity of care ensures a smooth transition of patient care between nursing shifts, whether this is for day shift to swing shift to night shift, and vice versa. This reduces the risk of errors in improving patient outcomes. For patient safety, effective handoffs help prevent miscommunication and ensure that the information is accurately conveyed. For collaboration, handoffs promote teamwork and collaboration among healthcare providers. This allows for patients to receive the best patient care. Treating patients wouldn't be possible without the attendings, fellows, nurse practitioners, nurses, physical therapists, techs, social work, educators, shout out to Sue, our educator, and management working together as a team. And last, handoff is important for patient satisfaction. Well-executed handoffs contribute to a positive patient experience. Press Ganey uses Likert type survey with 5 responses: very poor, poor, fair, good, and very good. This helps healthcare organizations to improve the safety, quality, and experience of patient care. HCAHPS, which is Hospital Consumer Assessment of Healthcare Providers and Systems, is a set of survey questions about doctor, nurse, medication communication, staff responsiveness, hospital environment, discharge information, food service, and overall patient experience. Patient satisfaction also affects patient retention and compliance. Patients that are satisfied and feel valued by their care providers may be more likely to take an active role in their care. In a study that examined handoff, researchers found that ineffective handoffs have been estimated to be responsible for about 40% of adverse events, such as treatment errors and patient death. I'll repeat that again. Ineffective handoffs have been estimated to be responsible for about 40% of adverse events. This is why handoff is very important, so we can prevent these adverse events from happening. With that being said, there are barriers to thorough handoff. High patient volumes and staffing imbalances can create time pressures that hinder thorough handoff processes. If you take a look at the bar graph on the right, this lists the cardiac catheterization lab volume at Mount Sinai Hospital over the last 5 years. According to this report, if you look at 2022, we had over 15,000 cases. We are constantly admitting and discharging patients. To go into detail, I can start my shift with 4 patients who had an intervention the day before, and all of those 4 patients can be discharged the day after as long as the labs are within normal range, EKG is normal, and the patient is feeling well without any complications. In other words, I can admit 2 to 3 new patients from cath lab that day. This is a fast-paced unit with a high patient turnover rate, adding to that time pressure. Second, we have communication challenges. This is a busy environment that can cause distraction when taking report. For example, we have the telemetry alarms that can alert if a patient's heart rate is above or below the alarm parameters, or if the patient is having an arrhythmia. We also have bed alarms that can ring if a patient is on false precaution and is moving towards the edge of the bed. The Vocera also alerts if a patient is calling or is also having an arrhythmia, and there are constantly patients leaving on and off the floor to go for tests such as ultrasound or a CAT scan. With this busy environment, it can cause distraction when taking report. But another communication challenge is the technical language. When I first started on 7 East a year and a half ago, I was receiving a report with my preceptor and I had no idea what ROTA, PCI, or DES meant. I had to ask my preceptor to explain it as well as study it at home. As medicine and technology advance, Mount Sinai continues to educate themselves to stay updated with these advancements. And last, there are human factors such as fatigue or stress that can affect healthcare providers' ability to conduct effective handoffs. Addressing these human factors through strategies such as workload management, as well as communicating with our coworkers and charge nurse, can improve the quality of handoff. If I'm about to discharge a patient, but cath lab is also calling to give report, I can ask my coworker to either take the report or help discharge my patient. Although there are barriers to thorough handoff, there are ways to overcome it and achieve high-quality handoff. This was created by the Joint Commission. These are their 8 tips for high-quality handoffs, which help implement best practices. First, determine the critical information. What type of procedure did the patient have, and what's the protocol? Is it Q15 for 1 hour, Q30 for 1, or did they just have a diagnostic where it's just Q30 for 2 hours? Second, standardize communication tools and methods. I'll go over this in the later slides, but this is SBAR and the report sheets. Third, don't rely solely on paper or electronic communications. Report is given through the phone from cath lab to inpatient units, as well as at the bedside. 4, combine information received from different sources. 5, ensure receiver gets all necessary information. 6, conduct handoff in quiet, interruption-free area. 7, include all team members in handoff. And 8, utilize EHRs and other technologies to enhance handoffs. In Epic, we have access to the notes, which allow us to see the types of procedures that the patient had, as well as what the patient's received medications. Although the Joint Commission has 8 tips for high-quality handoffs, which help implement best practices, I just want to sum it up to 3 things: plan, communicate, and prepare. For plan, make sure you have a report sheet. One of the worst feelings is cath labs calling and you open that drawer and there's no report sheets left. Also, limit those interruptions. Go to a part of the unit that isn't overly crowded. Don't sit at the front desk where there's patients constantly going in and out. Second, we have communicate. Be clear and ask questions. When taking report, if there's something that you don't understand, ask. If there's something that you need to be repeated, ask for it to be repeated. If you feel like the person's speaking too fast, ask them to slow down. It's okay. Just the other day, when I was taking a report from cath lab, I had a patient who had a KBI. I had no clue what KBI and end up learning something new. For those of you who don't know, if you take a look at the right hand of the screen, this is a kissing balloon inflation. It's a technique used to treat patients with coronary bifurcation lesions. It involves simultaneously inflating two balloons, one at the main vessel and one at the side branch. As it's being inflated, they essentially kiss, which is why it's called kissing balloon inflation. Later that same day, as I was giving a report to a night shift new grad nurse, I was able to educate her on this very technique. Sorry, I forgot the last one. So the last one is prepare. If a patient has a sheath in place, I need to prepare the room with a few items. I need a femstop, atropine just in case the patient vasovagals, suture removal kit for when the sheath is removed, along with Tegaderm 4x4 and a thrombix. Anticipating what the patient will need helps for a smooth transition for the patient to be moved from the stretcher to the bed. Along with preparing, it's crucial to continue to learn, especially as medicine advances every day. So now let's go back to nursing school where SBAR was ingrained into our brains. SBAR is a communication tool that stands for situation, background, assessment, and recommendation. Let's break it down together in regards to post-intervention. For situation, this describes the patient. What's their name, age, gender, code? Do they have any allergies, and what's their admitting diagnosis? B stands for background. This provides their medical history and recent events such as their procedure. A is the assessment, what's their head to toe and their latest vital signs. R is for recommendation, what time is their bed rest done? Are they on any fluids and for how long? What time are their scheduled labs, and what's the plan for the patient moving forward? This is Mount Sinai's cath lab handoff form that is passed along through the different areas of cath lab. Handoff is given through the phone if the patient is getting admitted directly to an inpatient unit, such as CSDU or CCU or 7 East and 4 North. The nurse that accompanies the patient to the unit allows for the receiving nurse to ask any additional questions during that second handoff. Now, this is the 7 East handoff form. This is a double-sided report sheet. The form on the left side is when taking report from cath lab. An example of a procedure would be a left heart cath, PTCA, cutting balloon D, S×1. What's their admitting diagnosis? What site did we access? Was it their radial? Is there hematoma present? What type of closure did they have? Was it angioceal, vascade? And as well as their medical history. In the middle, we have the post-catheterization assessment. What's their mental status and what's their latest vital signs, as well as what medications did the patient receive, whether that's Versed, fentanyl, heparin, aspirin, or Plavix. And at the bottom, we have the post-cath orders. How long is that bed rest for, fluids, labs, and any medications that they need to receive. On the right side, we have when we're taking a report from an outside hospital or from CSDU or CCU. This includes their head to toe, and the space on the right allows for nurses to write any critical events. This tells the story of the patient. Key takeaway: by practicing thorough handoff, you're not just transferring information. You're paving the way for seamless care transitions and making a profound impact on patient outcomes. Together, we're delivering extraordinary healthcare. Thank you to Beth Oliver, Sharina Guy, Thomas Jeremita, 7 East managers, Carmela Marasigan, Judy Blaza, and to my 7 East team. I love you guys.